Good morning, everyone. Today I will be presenting my project, Macular Flow Voids on OCTA as potential biomarkers for silent cerebral infarction in pediatric sickle cell disease. I would like to thank our financial support that grants Research to Prevent Blindness and the T.Y. Alvin Liu Research Grant Award. The preliminary data was previously presented at the Macula Society. Sickle cell maculopathy is a well-recognized and prevalent in patients with sickle cell disease. Macular morphological changes are characterized by macular splaying and inner retinal thinning. Patients with sickle cell disease are known to have decreased macular vessel density on OCTA, more commonly found in the deep more so than the superficial capillary plexus. These changes are commonly noted in the temporal macula, a well-understood watershed zone of the retinal circulation. This is a figure from a previously published cohort study by Dr. Ong and Dr. Scott of pediatric sickle cell disease patients. These images are from 3 different 10-year-olds that highlight the decreased retinal thickness and macular vessel density in the bottom 2 patients with sickle cell disease as compared to the unaffected control patient in the top figure. Furthermore, this study provided the patient cohort. For our current study, a retrospective post-hoc analysis of the prior cohort. Silent cerebral infarct is the most common neurologic injury in sickle cell disease. These infarcts occur in the cerebral deep white matter and most commonly are found in the watershed regions of the middle cerebral artery and in areas of low blood flow. The American Society of Hematology recommends baseline brain MRIs at least once in early school-aged children and once in adults with HBSS disease or sickle beta thalassemia. The primary objective of our study is to determine if there is a relationship between macular and microvascular abnormalities noted on OCTA and silent cerebral infarctions on cerebral MRI in pediatric sickle cell disease. The secondary objective of our study is to determine the association between systemic complications in pediatric sickle cell disease patients with and without silent cerebral infarction. This is a retrospective post-hoc analysis of children with sickle cell disease from our prior cross-sectional cohort study. 34 patients with 68 eyes from the prior study were reviewed, of which 28 eyes from 14 patients met inclusion criteria. Macular scans were analyzed and the following variables were captured: inner retinal thickness, superficial capillary plexus density, deep capillary plexus density, and presence of macular thinning on OCT. Brain MRI with FLAIR sequence were reviewed by a pediatric neurologist and neuroradiologist with expertise in managing pediatric patients with sickle cell disease. Silent cerebral infarction was defined as 3 mm of area of infarction in at least 2 imaging planes, as established by guidelines of the Silent Cerebral Infarct Trial. Of the 14 patients in our study, 8 met criteria for silent cerebral infarction. Baseline demographics were compared between patients with silent cerebral infarctions and patients without silent cerebral infarctions. There were no differences noted between the 2 cohorts with regards to gender, age, race, or type of hemoglobinopathy. Systemic and ocular characteristics from fundus photos and retinal OCTs were compared between the 2 cohorts. There were no differences noted between the 2 cohorts with regards to distribution of systemic comorbidities or treatment modalities. Patients either had no evidence of retinopathy on fundus photos or non-proliferative changes. And there was an equal distribution in the presence of macular thinning between the two cohorts. OCTA variables compared included inner retinal thickness measurements, superficial capillary plexus, and deep capillary plexus vessel density. There was no difference in the inner retinal thickness measurements between the two cohorts. And although patients with silent cerebral infarctions had reduced vascular density parameters in the superficial capillary plexus, this did not meet statistical significance. Reduced capillary density in the deep capillary plexus was also noted among patients with silent cerebral infarctions and did meet statistical significance in the temporal parafovea. This is a 13-year-old patient with hemoglobin SS disease, and here is a multimodal image documenting decreased capillary density in the deep more so than the superficial capillary plexus, subtle peripheral capillary drop-off on ultra-wide field fluorescein angiogram, and thinning on OCT in the temporal macula. This is an example MRI image from the same patient with a prior retinal imaging showing hyperintense foci as demonstrated by the red arrows measuring at least 3 millimeters identified on MRI T2 FLAIR axial and sagittal planes. The two main conclusions from our study include patients with silent cerebral infarctions were found to have lower vessel density in the DCP compared to those without silent cerebral infarctions, particularly in the temporal deep capillary plexus. As highlighted earlier, this area represents a vascular watershed zone with high levels of oxygen extraction. And second, vascular density changes were noted prior to any structural thinning, corroborating research previously done by our group. Finally, I would like to thank everyone for their help with this project, especially our patients.